It's an enormous pleasure to welcome everybody to the to Grand Rounds today, to the Arresti inaugural. To the continued Arresti sponsored Grand Rounds, and that we're trying to focus on things that are relevant to Julie's incredible legacy at the BI. So Julie was, as many of you know, really the preeminent clinical cardiologist at the BI for decades. He helped build an incredible referral network, and really, I think, was an example for many generations of trainees of how to be sort of a doctor's doctor. There are people in this room, including Joe, whose I think career was modeled after Julie's, and certainly for a good part of my career, whenever I struggled with a case, particularly a valve case or any complex medical situation, Julie's always the person that we went to, and we're incredibly lucky, I think, to still have, many of us still have him in our lives, have him participate in Grand Rounds remotely, and continue to ask incredibly insightful questions. And we thank his family as well for helping to create this lectureship. It's a particular honor to have Roger giving this lecture, and I think Roger was trained by Julie and has really become one of the elite interventional operators in Boston and nationally, and has taken our structural heart program now to a new level. Roger's the person who we all go to when something needs to be done that's requires some creativity and skill, and I think I hope we're going to hear about his vision for the present and future of this program.
Thank you so much. It is really an honor and a privilege to be in the presence of really Julie today. I remember I came in 1992 to the old BI. And at that time there was still war in Lebanon, and Julie took me under his wing and always kind of ensured that he was one of the really amazing mentors and kind of amazing human beings, amazing doctor, and full of kindness, full of empathy, and full of compassion. But kind of he has been called by everyone a teacher, a mentor, a colleague, and a friend, and he is loved and admired by all. And kind of I put a picture of his family, but I want him to know also that we are all consider him our family. I've considered him as a father and as a mentor and as a friend, and I've always gone to him for advice about my career throughout the years. Anytime that there was a major decision that had to be made about leaving or staying, starting a company, or moving on, I think kind of I went to Julie because I knew that I would get the honest answer, and then he always had the true north in his thoughts and in his wisdom. But what I've done, and we can spend the entire lecture on honoring Julie, but what I've done is I've called all the previous trainees, and I had 5 slides before with all the pictures, but then kind of until last night I was getting still quotes and images and anecdotes and stories. And in fact, the last person I called was Stafford Cohen at 10:30 last night. Woke him up from sleep, and he gave me the story about the sailboat called Research, and it has been amazing. But I know we're gonna talk about a lot of things, but I want to talk about some of the quotes from trainees and colleagues that have gone on, and it really is amazing. It basically everyone says the same thing almost, but I read some of those. Remains a role model for me to this day. He is the consummate physician who truly cares for his patients. His kindness, patience, and demeanor bespoke a truly compassionate nature. He never spoke ill of anyone and was always supportive and nurturing. He made me the leader and family woman I am today. Single-handedly put BIH on the map with his patients entering the Barry study. And basically Barry was a very difficult study to recruit for because it was randomized surgery versus angioplasty, which was new. And only Julie's patients, in fact, were randomized in this study, and in fact put the BI and its interventional program on the map. A lot more quotes, a lot more issues, and the one that I love the most from one of the previous fellows is, if you can be anything in life, be kind. And I can't tell you how many tears were shed in my discussions with a lot of the previous staff, a lot of the previous fellows, and who are who staff the hallways of academic medicine throughout the US. But for structural heart disease, we always think it's a new field. In fact, it's not. It is, in fact, with Rubio Alvarez and Limon in 1952, with their pioneering work to relieve critical pulmonic valve stenosis with blade pulmonic valvuloplasty, heralded a cascade of procedural and technological advances that now contribute to our ability to treat and often cure structural and valvular heart disease. And it is a new field that has emerged in the world of adult cardiovascular medicine, which encompasses a myriad of non-atherosclerotic conditions, adult congenital, cardiomyopathy, and valvular disease. And this growth has evolved from the rapid development of new technology enabling therapies for conditions previously treatable only with open heart surgery or even not treatable at all. And we always talk about being less invasive means treating more patients, and that's actually true. The less invasive the approach, the wider the applicability. And we want to go from, I see Dr. Thur in the audience, so I shouldn't have had the open heart and the open chest on the side. But, in fact, we treat the minority of patients with open heart surgery, but if something is much lesser invasive, then probably it would be applied to all of these. But the true catalyst of structural heart disease field has been a multidisciplinary approach to cardiac therapies. Cardiologists, cardiac surgeons, heart failure specialists, imaging specialists, anesthesiologists, PCPs, nurses, technologists, geriatric specialists, everyone all working together for patient-centric strategies. And obviously revolutionary imaging with CT, 3 and 4D ultrasound, as well as MRI, has enabled a lot of these advances. And structural is really not a novel field at BIDMC. And I know that we've had pioneers at every level of the structural field, starting with the 90s all the way to more recent. And you recognize most of the people in the images. But I think we've been very fortunate from the days of Ray McKay, doing valvuloplasties on cadaveric aortic stenosis and starting that program in the early 90s to kind of, our pioneering work, at least with some of the new percutaneous catheter valves. But the milestones of the structural heart programs are important to state. I think, to date, we've done more than 1,500 TAVRs. We've done more than 350 mitral clips, which are to treat mitral disease. We've had more than 200 patients enrolled in clinical trials, including extreme risk, intermediate risk, low risk TAVRs, bicuspid TAVRs, transcatheter edge-to-edge repair, tricuspid clips, catheter-based mitral and tricuspid valve replacement. We've had 400 patients enrolled in the HIS recording study with Al Buxton. And we do a lot of advanced TAVR and mitral techniques, including BASILICA, valve fracture, alternative access, lampoon. We'll talk about all of these things. And we get referrals from Maine to New York, for many of these advanced therapies. But this is just kind of a brief slide showing really our growth over the years. And then, in purple is the TAVR volume. And then in green is the mitral volume. And you can see that we've been growing steadily over the years. This is the 2023. And the expectation is that we would reach almost, basically 600 structural heart procedures this year. In addition to that, our mitral program, just to illustrate how we compare to other institutions in the city, this is BIDMC in the first column, and then you can see all the other hospitals in town with really just kind of, we do double what many of the other centers do. And all of it is really thanks to an amazing team of interventionists, of cardiac surgeons, of imaging specialists, of clinical cardiologists, and of nurses and technologists that enable this to happen. But the field of structural heart disease at BIDMC started with the congenital, with ASDs, VSDs, PDAs, Gerbeaud defects, which are no longer surgical diseases. Kind of ethanol septal ablation also was done. And this slide shows a typical ASD, which is nowadays measured with 3D imaging, and then the device here deployed across the septum. And then basically with 3D imaging, we're able to close many of these large defects, whether they are in the atrium, across the ventricles, or in the PDA. In addition to that, newer devices that are coming along, and that's kind of the beauty about this field. It does seem that there is a lot of development of devices, but this is a patient that has absolutely no rim for their atrial septal defect. And then we have newer devices that enable to close many of these. This happens to be the Gore septal occluder, which is a very flimsy device that enable to close any defect, as it goes. PFO and cryptogenic stroke was a major driver of the structural volume in the past. And, it still is. And, basically there are several studies that have shown that in a subgroup of patients with PFOs and cryptogenic stroke, closure is indicated. And this is a typical patient with an atrial septal aneurysm, which makes it a very high-risk PFO. And then this patient is closed by an atrial septal occluder that enables these patients to kind of have a much lower recurrence of the stroke risk. And the heart-brain meeting has been a multidisciplinary approach led by Dr. Poulain that has enabled at least a lot of these patients to be streamlined through the process. And then we always do what's best for the patients. We do a lot of other small things, such as paravalvular leak treatments. Sometimes after TAVR, after surgical aortic valve replacement or mitral valve replacement, you can have a leak, one of the stitches comes off. And then typically this is an example of a 62-year-old lady with hemolysis from her paravalvular leak. And you can see on this slide here, the PVL coming from around the valve. This is a 3D reconstruction, as well as 3D volume showing the leak coming from one side of the valve itself. And then we're able to go in, as you can see, with a device that closes it on both sides. And then after that, the leak disappears and then the hemolysis gets better. Sometimes it requires additional devices, but most of the time, these are very kind of satisfying cases. However, they were, it's a small volume. These were all niche procedures as it goes. However, aortic stenosis was the first mainstream application that has propelled the structural field into really just being, a high volume driver for many institutions. We all know the 1968 slide from Dr. Braunwald with regards to, whenever you have symptoms, then, probably you should have surgical AVR, which improves survival symptoms and LV function. And that basically has been the driver for many of the treatments of AS patients. However, it was discovered early on that a lot of the patients were not getting surgery, either because they were too sick or they were too old or they were too afraid of open heart surgery. And this led to the development of TAVR devices, which are transcatheter aortic valve devices that are either balloon expandable or self-expanding, and it has enabled the rapid progression of the field. They were first demonstrated in prohibitive risk patients, then in high-risk patients, then in intermediate risk patients, and then in low-risk patients. And this slide shows the low-risk population with, in fact, improvement in death, stroke, and rehospitalization. And then looking at all the variables, TAVR was, kind of as good, if not better than surgery, obviously up to 12 months. So this is the one-year outcome. And that has led to the approval of these devices for low-risk indications for severe aortic stenosis patients. And the major message from the new guidelines have been that all patients with severe valvular disease being considered for valve interventions should be evaluated by a multidisciplinary team with either referrals or consultation with a comprehensive valve center. And that started the heart team, whereby we work with our cardiac surgery colleagues as well as clinical cardiologists to do what's best for the patient and to kind of, take into account everything that goes from there. But also it opened up, kind of the entire group to this, the shared decision-making, which has been essential for this. Gone are the days of paternal or maternal medicine, whereby, we tell the patients what to have. And I know that Julie has always been an advocate of taking the patient's opinion as well as the patient's wishes and values into consideration with every decision that he made. But it is a collaborative model in which healthcare providers and patient jointly consider treatment options and the patient's values and preferences. It involves multiple steps to ensure that patients and providers understand the risks and benefits of all treatment options, including shared decision aids. And we provide the patients with these booklets that kind of describe everything in a lay term, as well as try to educate them as well as much as we can with regards to this. And it's been demonstrated over and over again that, when patients are asked, almost half of them would prefer to just have a shared decision-making rather than either deciding on their own or being told what to do. 43% of patients in this particular study showed that, said that I prefer that my doctor and I share responsibility for deciding which treatment is best for me. And that is important, at least in the way that we approach a lot of these patients. We've established, the multidisciplinary clinic where cardiac surgery as well as cardiology and the referring physician and the family and everyone involved kind of basically participate, and they are educated on the process. This is kind of the typical heart clinic that we do in terms of, you have the surgeons, you have the cardiologist, this Dr. Pinto, myself, Mark Tuttle, as well as BG, our current structural fellow, and their PCP, their other cardiologists, their family members. And we moved from a flawed informed consent to an informed choice. Rather than just telling them, this is what we'll do, these are the risks, we tell them exactly what our thought process is. And there is equipoise in most of the procedures in medicine. And we tell them about the uncertainties. We explain to them that we don't know much about TAVR in 20 years. Surgery has been done for 50 years. But we tell them all our uncertainties, and we make the decision with them. In addition to that, this is our meager attempt to bridge the healthcare disparities. And what we found over the years is that basically well-to-do patients and, they come with their VIP MD, with their 2 cardiologists, son-in-laws, with their cardiac surgeon, friend, and they come by deciding exactly what they want. And you'll see later on that that has an impact on what they do in terms of TAVR or not. And then you have the patient from Brockton that comes in and they tell us, do what you want to do. And, please tell me what to do. And in fact, us educating them and telling them and making them participate and control their healthcare the same way that, well-to-do patients would, I think is our small contribution to this healthcare disparity in terms of deciding what the best treatment choice is for them. And for example, this is a 68-year-old patient with symptomatic bicuspid AS, low risk for TAVR as well as SAVR. And, 9 to 11% of our patients have, in fact, bicuspid disease. And then we sit down with them, we just explain to them all the uncertainties. And these uncertainties are getting less and less with time, as we'll see in a few minutes. But typically, we go in, we just go ahead and implant a balloon expandable valve. Typically in bicuspid patients, we use cerebral protection because of the slightly higher risk of stroke. And then the patients go home the next morning, and then the patients can drive within a week. And then the patients usually just, are pretty happy with the decision that they made. Younger patients, we offer them mechanical valves. We talk about the lifetime management of many of these patients, and that's kind of important to discuss in a few minutes. But the TAVR formal process is, has been streamlined by really an amazing, staff of APPs and nurses and cardiologists. But typically we get a referral, we do a CT and an intake call, and then the patients would come by for the analysis of their CT, and then they have a cath if coronary anatomy is unclear, and then they get to the multidisciplinary visit. You know, we're trying to shorten that time as much as we can by having more slots on the procedural side, but I think it has made patients really well, streamlined into the process of getting all of these techniques. But these are the BIDMC TAVR program firsts. You know, we streamlined the evaluation using CT imaging to clear coronaries in more than 70% of patients, with cath at the time of TAVR in about 15% of patients. In fact, less than 15% of our patients need two procedures. And probably out of 350 TAVRs last year, we only had 3 patients whereby we said, look, you know, we found something at the time of cath, at the time of TAVR that might change our management. Typically, if patients have diabetes or their coronary anatomy will impact the decision to have SAVR versus TAVR, then we do it before. We have streamlined the procedures with monitored anesthesia care, single access, end of procedure ultrasound, next day discharge, mobile telemetry, which we're still kind of trying to find the best one. And then we had a first in Boston with nurse-led sedation, keeping the tradition of nursing empowerment at BIDMC and improving recovery and minimizing cost. And in fact, in the TVT registry, we only had 900 nurse-led sedation cases last year, and then 100 of them have been done at BIDMC. So I think we can lead with that aspect. We also provide a lot of advanced TAVR techniques with alternative access, BASILICA, balloon fracture of valves, and a lot of investigational devices. In CKD patients, and I knew that Dr. Steinman will be here, we do a streamlined process again. We do low contrast gated CT for the TAVR sizing and non-contrast torso for circumferential calcium in the aorta and iliacs, and then vascular ultrasound at the access site. And if they have severe CKD or pre-dialysis, we don't want to push them into dialysis, so we use TEE sizing. And this shows really the ultrasound that we use, and then the CT is not as well defined, but we can always size them according to this very low contrast CT. And Diana Litmanovich has been instrumental in just kind of doing this, and I think we are the only site in Boston that are doing these low contrast CTs. Now, if the patients cannot have transfemoral TAVR, which is the one that they can go home the same day, then basically they usually have what we call alternative TAVRs, alternative access TAVRs, which at BIDMC is only 1 to 2% compared to about 5 to 8% across the country and in TVT. And part of it is our close association with our vascular surgeons and really kind of our multidisciplinary approach to most of these patients. Vascular complications remain the most common adverse event in TAVR, and then transfemoral approach remain our first, second, and third line strategy, followed by percutaneous subclavian or axillary, transcaval, and transcarotid. And I just wanted to kind of give the 10,000 feet view of some of these procedures, when they are done on your patients. But this is an 87-year-old lady with severe symptomatic AS with a mean gradient of 49 and prohibitive iliacs. You can see these are the CFAs, the common femoral arteries. These are the iliacs, and that's the aorta. And in this patient, obviously a transfemoral access is out of the question. Our options would be to do either transcarotid, transaxillary, or transcaval. And then this is the axillary ended up being a great one. And we use CT extensively with multiplanar reconstruction to kind of guide a lot of our access points. You can see in this that the carotid was not a great option. So we went with the left axillary, and typically we do it percutaneously or surgically in some patients. And then, we go in and we do the same thing that we do from the leg with percloses. And at the end of the procedure, we sometimes tamponade with a balloon. And then, the patients again go home either, the next day or 2 days later. One of the things that kind of we pioneered, at least in Boston, has been the transcaval approach, which we haven't had to do for a while because of the availability of other techniques nowadays, but we still have it in our armamentarium for some of these patients. Sometimes if you don't have an access in the subclavian or in the carotid, we look at the CT scan and you'll always see that the vein, the IVC, is close to the aorta, and this is an 81-year-old man with severe AS, and then the patient had severe PVD with multiple surgical interventions, and simply just kind of a transfemoral approach was not feasible. The subclavians were not good, and what we do with these is we put a catheter and then a snare in the aorta and the catheter in the IVC, and we electrify a wire that goes, basically from the IVC into the aorta. And then at the end of the procedure, what we do is we just kind of close the aorta with a PDA device. And, you'll see probably early on before you release the device, there is still some flow, but luckily it just goes into the IVC and doesn't cause any problems. And then usually later on, just kind of that flow kind of goes away, and then the patients usually again go home either the next morning or 2 days later. And kind of we have all of these techniques that enable us to kind of tackle a lot of these patients and get a lot of referrals from all over the Northeast for many of these procedures. More recently, intravascular lithotripsy or shock wave, the more common term, has been kind of used successfully in a lot of these patients. And then typically what it does, it just kind of, in patients that have a lot of calcifications, with the shock wave, like the kidney stone shock wave, the lithotripsy, it just opens up the calcium in the iliacs and then allow us to do kind of a lot of these interventions. And that's why our alternative access has gone down significantly. And we were the first in Boston to just kind of use that technology for many of these patients with this. Now, the next question that comes up with all of this is, the lifetime management. And, kind of, we really didn't know 5 years ago that TAVR would last. Everyone thought they would last 1 year or 2 years. And, kind of obviously, now we're almost 7 to 8 years. And then, in this graph, it shows the 5-year data of the Evolut, aggregate patients. And, kind of basically what you'll see is the structural heart deterioration is similar between, probably slightly better with TAVR, but it's similar between surgery and TAVR. So at least we're not worse. And now we have 7-year data for some of the valves. And then again, it seems that, this is going the right way. In addition to that, we, currently in the US, 87,000 TAVRs are performed, 4,000 TAVR and SAVRs. These are TAVRs in surgical AVRs, and then only 400 TAVRs and TAVRs, which tells you that, kind of if TAVR failure was going to be a major issue, we would see a lot more of these TAVR and TAVRs. In addition to that, one of the major issue of, for a while, our thought is let's do surgery first, and then, TAVR afterwards, TAVR and SAVR. But TAVR and SAVR is not as simple as everyone thought. And the reason for this is a lot of times the surgical valve is placed a bit supraannular, and so that the coronary arteries are a bit low. And then as you can see from the CT, you can see this is the origin of the left main in red. This is the origin of the RCA in green. And you'll see that they are almost below the frame of the valve. So if you put a new TAVR inside, what will happen is that it would occlude those coronaries, and the risk of occlusion can vary anywhere from 7 to 25%. And if you look here, is we simulate a valve, and then we measure what's called the VTC, or the valve to coronary distance. And in this particular case, it's 2.0. Usually anything above 5, kind of probably you get away with it if the patient doesn't need another intervention. However, it is concerning. And you can see on this CT how when you put a valve, it occludes the coronary arteries. Kind of that's a simulated valve, and you'll see that both the left main and the RCA will get occluded. And, obviously we have answers for these. This is an example of a BASILICA procedure, which is a procedure we do to lacerate the leaflet. so that we take it out of the equation. So now it's not pushed anymore by the TAVR and SAVR that we do. And this is, you can see on this, is really just kind of what we do is we put a wire across the leaflet, we snare the wire, and then we just make a flying V, which we scrape the wire a bit. And then on the way back, we just electrify it, to using the cautery device. And then we cut the leaflet that way. And that has been kind of quite successful at BIDMC. And I think we are one of 25 centers in the country that do these procedures, and we get referrals of these from all over the Northeast. You can see how the flying V is pulled, and as we're pulling, we inject dextrose so that most of the electrical charge stays in the wire. And we're developing new devices that might be more helpful, including electrified grasping devices and all of these issues. This is another example, and you can see here from the coronary artery is it's so close and below the frame of the aortic valve that what we do is we advance a wire and then we snare it with a snare. And then we just go ahead and lacerate the leaflet to be able to just put a valve without compromising the coronary artery. And this is the data from the multi-center international BASILICA registry. Basically it was 214 patients only. We contributed, I think, 33 patients to those. You can see that it was quite successful, and the risk of obstruction was quite reduced from the 20% that was, and these are all patients with high risk for occlusion. Fortunately, none of the occlusions happened here, but again, this is something that we always worry about, and we sometimes protect these patients even after doing BASILICA. Now, the other kind of issue is a lot of times the surgical valves are smaller, and as they get stenosed, what they do is they kind of cause more higher gradient, but we're limited when we do a TAVR and SAVR to the size of the existing surgical AVR. And then what we can do for many of these valves, except for the trifecta, is basically we can use a bigger balloon and we can fracture the frame. And that usually allows us to put a bigger valve or a bigger TAVR valve in those. And that is routinely done in most of our patients with TAVR and SAVR, unless it's a trifecta, as I said. And typically what you do, you can see how the TAVR initially is kind of limited by the frame. And then we put a huge balloon and then kind of fracture the frame of the valve. And usually kind of you get a reduction in the gradients to the single digits. And that work was initially done by Keith Allen and David Cohen, one of our previous faculty early on down at Kansas Heart. Now, the issue is, we're doing amazingly well with the TAVR. However, we can always do better and treat all eligible patients. And this is really kind of a map of the diagnosis as well as the treatment of these AS patients. And you can see that a lot of the treatments happen mostly around the major hospitals. A lot of patients that are in Brockton or Chelsea or South Shore, or even Plymouth, tend to have less diagnosis as well as less treatment of their aortic stenosis. And then that has been a major, kind of focus for our program. And, it's amazing that 24% less likely for Black patients to receive AVR, anything, SAVR or TAVR, than white patients. It's 9% less likely for women to receive AVR than men. This is all data from the TVT registry. And it's 10% increase in the odds of receiving a TAVR with every 10,000 increase in income. And that is fascinating in terms of, it's unfair. Obviously, if you're well-to-do, then typically you choose TAVR or you have a higher chance of getting your TAVR. And our approach to this has been, kind of multi-pronged. We're opening valve clinics in underserved areas and partnering with industry and foundations for transportation services. The first model that we have is going to be with Brockton Hospital and Andy Eisenhower, not Andy Eisenhower, Andy Weintraub, but Andy Eisenhower too in Maine, in central Maine too. But basically, and we've tried to identify the barriers. In addition, another major barrier to healthcare delivery has been dental clearance, as simple as that. Typically patients that are well-to-do or that are from affluent, neighborhoods, they have routine dental care. And, as soon as we see them in clinic, they give us a dental clearance and they go and have their TAVR. Patients that are coming from under, served areas, we try to just get dentists to see them. And typically the dentist will ask for, a lot of procedures to be done before they clear them, for, uncertain reasons. And we have established a working group from Boston Dental School, from BU, from Tufts, and from the Harvard Dental School, and as well as private dentists to just try to figure out what the best way to do this. And it seems that we're gonna settle on, in terms of treating them, covering them with antibiotics, around, unless there is something major, and then dealing with the dental issues later on as a way not to delay their care. We have to enable clinical trial access for non-English speaking patients. And then we're partnering with community organizations for screening and treatments, including, portable ultrasounds at a couple of the community centers in Brockton. Again, Andy Weintraub is our partner in this. In addition to that, there are ongoing studies with earlier TAVRs or SAVR. Should we treat symptomatic moderate AS? Should we treat asymptomatic critical AS, and all of these issues? And this is data from the randomized clinical trials aggregate in terms of looking at patients with moderate AS, and it does seem that they derive the same benefit as patients with severe AS. And currently there is a moderate AS clinical trial that just started enrolling recently at the BI. And last but not least, with regards to the aortic space, is what about aortic regurgitation? Well, it's coming. GeneValve Trilogy TAVR system is courtesy of Dwayne Pinto, one of our faculty members that was very active in the structural space. But this is the valve, and then typically these valves are deployed for pure AI, and then it has been quite effective. And I think it will get approval for extreme risk AI in the next quarter, the first quarter of 2024. Now, mitral disease is basically the big one, but again, it's the least developed. And obviously, we all know the rheumatic mitral stenosis, and we're seeing a resurgence of some of these. However, typically most of these patients are treated with balloon valvuloplasty, and then basically they do quite well for a long time. However, the major one is really mitral regurgitation, and if you look at it, it's about 4.1 million patients, MR patients in the US. Eligible for treatment is about 1,600,000, and only 30,000 mitral valve surgeries. So it's clearly that these patients are undertreated for various reasons. And typically we we divide MR into primary MR, whereby it's it's a disease of the mitral leaflets, either a flail or a prolapse, or Barlow or fibro, basically a disease of the actual mitral valve itself, or it can be functional, whereby it's really heart failure with dilatation of the annulus, which becomes a vicious cycle: volume overload, LV dilatation, functional MR, increased volume, and then leading to worsening MR. And it's very clear that if you have MR and if you have heart failure, then your mortality is quite high, and then you don't do as well as patients with no MR. And that led to the COAPT trial, which has been really the first device trial, in the mitral space, or that has shown a mortality benefit. It enrolled 614 patients with the GDMT, and then or a MitraClip procedure, and there was a dramatic reduction in heart failure hospitalization, dramatic reduction in mortality, and then co-management with heart failure specialists and interventional cardiologists, key to the success of the trial and to the success of the application of mitral therapies to many of these trials. And this is a couple of examples. 90-year-old presented with a STEMI in 2017, complicated by chordal rupture causing severe MR and cardiogenic shock. He had a PCI of the circumflex artery, And then, he was exceptionally sick. And then what he had is this P2 flail that you can see here on the 3D image, and then with really kind of massive MR. And, the patient had a balloon pump, and kind of, surgery at 90 was contemplated, but the patient did not want to have surgery. And this is in 2017. So we just went in with a clip. You can see that the patient is in fact sick with the tachycardia. And then, as soon as we put the clip in, the MR kind of almost went away. And this is really kind of the results that we get in many of these patients with simple P2 flail. And then this patient, this is the pre-mitral clip V waves, and that's the post-mitral clip V waves, almost complete resolution of the V wave. And the cardiac index, kind of basically went up from the sub ones to 2.4. And, the patient did well. And in fact, in 3 years later, he came back and he had, kind of mild to moderate MR at most. Now he had his AS, and, kind of probably he'll have TAVR, at some point in time. Now, this is a 69-year-old patient, and success brings, success, I guess. 69-year-old patients with late presenting acute MI, status post RCA PCI, found to have severe MR. And then typically what happens is, initially all these patients went to surgery, and having a surgeon as an integral part of our team, kind of says, well, kind of there is, let's do it with mitral clip. She was on a balloon pump, her creatinine was rising, and then, surgery would have been problematic. And again, the same process, we did mitral clip on this patient, and then the balloon pump was out the next day, and she was home after 5 days. And this is an example of how working, cardiology and cardiac surgery together, as well as imaging specialists, can lead to a lot of these issues. Now, studies are ongoing in lower risk patients. And this is, for example, a 67-year-old with hypothyroidism and generalized anxiety disorder. He didn't want surgery. Surgery was recommended 10 years ago, and he canceled it 4 times, usually the day of surgery. So the next time that we wanted to send surgery, the surgeon said, no, please don't schedule him. And he saw psychiatrists and all of these issues. But again, with shared decision-making and with a full understanding of the limitations, is he underwent mitral clip, and you can see the severe MR on this patient. And then typically the same process. This is the clip procedure. We just go ahead and capture the anterior leaflet. And then typically a lot of the patients have, kind of very little MR afterwards. In some more difficult anatomies, you can have more residual MR. But, again, these are, the non-invasive or minimally invasive nature of these procedures enable you to just kind of, get it done repeatedly if needed. And we've done more than 350 clips, no procedural mortality, and, the outcomes, have been quite good. In addition, there are next generation edge-to-edge repair devices that are coming online. This is the Pascal device, which the BI has been instrumental in investigating, and then led to the approval of this device. And it's really not inferior to mitral clip, but that shows you is now mitral clip or transcatheter edge-to-edge repair is becoming the comparator to a lot of these studies. In terms of any time that there is a study of percutaneous valve, it is compared to mitral clip because at least the FDA considers it as kind of the comparator in intermediate and high-risk patients. But this is a typical patient, 79-year-old with severe scoliosis and severe MR. And then, the advantage of this technology is that it has less entanglement and probably kind of more reliable to place. And, kind of the study for the functional component is still ongoing. However, kind of the structural component has been approved, and we'll have it here soon at BIDMC. Typically for this device, if you have just a slight amount of MR or recurrent MR, it is much easier to kind of put a second clip because there is less interaction, and that allows you to end up eventually with minimal MR at the end of the procedure. Now, what if repair is not an option? And typically for many of these patients, we do valve in valve or valve in ring. These are existing valves that are present, and that's an example of a failed bioprosthesis, we typically cross with the wire, dilate the septum, and put a sapien that's designed for the aortic position in the mitral position, and that is approved for use in bioprosthetic MVRs as well as rings. And then typically, these are, again, very rewarding procedures. The patients is in cardiogenic shock, and typically you just kind of, fix put a new valve, and then, sometimes we have sent patients home the next morning, or even if it's elective, sometimes the same day. And that's kind of, what you do with these is the valve would look like, and then, it expands inside the existing valve, and then there is minimal MR, and then the gradient is limited by at least the size of the valve, although we can fracture these valves in many patients. The more difficult one that, again, is bringing BIDMC a lot of referrals, as well as, kind of a lot of notoriety, at least, is the valve and MAC. And sometimes you have so much mitral annular calcification that basically it causes stenosis or MR. So in these cases, we cannot use MitraClip. And then, the option is just to put a sapien valve inside the MAC. And this is an example of how much thought is put into many of these procedures. This is a CT MPR, and then that's the amount of MAC. Typically, if we have 270 degrees of MAC, we can just go ahead and put a valve and it will anchor well. But you can see here that the LVOT is going to be completely obliterated. And so the neo LVOT here is very small. And what that tells you, in fact, is that if you put a valve, it's going to cause severe LVOT obstruction with a lot of problems in these patients. And typically for these patients, and I think we're one of 2 centers in Boston and the Northeast that does this, is we do what's called a lampoon procedure. And typically we put a catheter on the base of the anterior mitral leaflet. And then we do the same as we do for BASILICA, is we take the catheter and snare it and then pull it back. We do a balloon-assisted lampoon so that we can create a plane, and then we just kind of create a flying V, and you can see it here on the left, whereby we take this, we scrape the coating of the wire from the inside of the V. We inject some dextrose to kind of concentrate the charge, and then we pull back on the anterior leaflet. And you can see here how as soon as you do this, the anterior leaflet is lacerated. And then that enables you to just kind of go in with your TAVR and just kind of place it with rapid pacing without any issues. And all that we've created is we've taken out the anterior leaflet and enabled these patients to have the TAVR. And you can see here immediately thereafter, we measure the LVOT gradient, and you can see that, you see the defect here in the valve. That's where most of the blood goes out, and that's kind of a technique that enables us to treat many of these patients with this. There are 2 active clinical trials of TMVR at BIDMC recruiting patients, the Summit as well as the Apollo, and that's an example of the Apollo valve, which again, kind of most of the problems with these valves are LVOT obstruction, but with our lampoon procedure, I think that's gonna be a bit more feasible in many of these patients. Now, the last part of this presentation is really the tricuspid, which has been the forgotten valve with a high prevalence of TR in cardiac patients. For long considered a benign valve disease. However, data suggests it impacts survival. And, it really is, if you look at the severe functional TR versus trivial, the mortality is dismal. In addition to that, it didn't seem that surgery as a standalone procedure have made any difference in many of these patients with TR. And in fact, with the guidelines, tricuspid valve repair is beneficial for severe TR only if you're doing left-sided surgery. And, that's the only class 1 indication. Sometimes, class 2, if you have some severe symptomatic TR, but I think surgery is rarely done for isolated TR for this. And the initial data came all from the TriValve registry, which was a European, multinational European study that looked at the patients that were treated with a clip versus not treated with a clip. And then you can see that there was some benefit in the patients that were treated with a clip compared to not, or some benefit whenever you had procedural success or versus failure. However, these are not randomized trials, and then you cannot tell kind of if that data is accurate. And that's why the Triluminate trial was kind of an amazing trial, and the BIDMC was an integral part of this trial. It randomized patients with severe TR to medical therapy versus a TriClip, which is a transcatheter edge-to-edge repair, and these are the results. It did not show a difference in mortality, probably because of the small number of patients, but there was a significant reduction in tricuspid regurgitation. In addition to that, there was a significant improvement in quality of life. And surprisingly, this will be enough for the FDA to approve this device for use in the tricuspid position, because it has been the first device to improve this, and that's going to set a new paradigm, so that a lot of the newer devices are compared to TriClip instead of medical therapy. And that's a typical example of one of the patients we enrolled, 79-year-old patients with the status post MitraClip with no improvement in TR and liver congestion. And typically you can see what the problem is. This is the transgastric view with the septal anterior and posterior leaflet. And then typically what we do is we put the clip, we orient it, and then we just go ahead and grasp it using the TriClip device. And a lot of times we need multiple clips for the tricuspid position. You can see here how the clip was placed in here. Most of the residual TR is coming from the posterior septal location. So after a second clip, the amount of TR is reduced by more than 3 grades in this particular patients. And again, these patients do exceptionally well, even with a modest reduction in their tricuspid regurgitation. Now, the transcatheter replacement has also had a lot of success, and part of the reason is there is no left ventricular outflow tract, so we're able to do a lot of these patients that way. And so the TRISCEND study with the Evoque valve, the randomized study, which is done, so now it's mostly continued access, but the data will be presented in the fall. And if successful, I think it's going to be again a new paradigm in tricuspid treatment. And typically these valves have anchors that go below the leaflets, and then anchors that go above the leaflets. And we are forming a working group for lead-related TR, which I think is going to make a huge difference in the treatment of many of these patients. But typically, a lot of this depends on imaging. Most of these procedures cannot be done without amazing imaging. And then, typically what you do is you do MPRs and make sure that all the anchors are deployed, release the valve. And this is when the valve is released. You pull back on it, and then it just kind of releases. And typically kind of, the patients have no TR. And, so we try to avoid it in patients with RV overload or RV failure. Instead, we use a transcatheter edge-to-edge repair in many of these patients. But, I think this is the follow-up on these patients, again, with no MR, with no TR, and really just kind of most of the patients, go home within a few days. Some of the patients would need to be supported a bit more, particularly if they have RV failure. But however, it's very promising if you select the right patients in many of these. And if everything else fails, we put an IVC sapien in, reversed. And there is a study that's coming up called the trick valve, which will enable us to do this in a study rather than off-label. And in many of these patients, what we do is we put the IVC sapien, and that way we protect the liver from the TR. And then the newer valve is going to have a valve in the IVC and the valve in the SVC that will take care of this problem. But again, it has been an amazing journey, and lots left to do. Focusing on lifetime management is important. Initiative to reduce healthcare disparities and improve access to care. Expand shared decision-making to all structural conditions. And determine the outcomes of advanced therapies and predictors of success. And finally, improve patient selection, imaging, and guidance. And thank you so much for your attention. And thank you so much for every member of the structural team. And thank you so much, Julie, for everything that for your mentorship, for your friendship, and above all, for your kindness. It's often said that if you don't know someone, even if I don't know you, and after talking to all your trainees, and I've seen how many people loved you, I know that you are an amazing man.
Roger, thanks very much. I think Artie has maybe some questions with that, or? Great. Any questions?
Is there any effort you make a valve in the patient's own tissue? It's the same tissue, the artificial valve implant that you will get.
So obviously, kind of, all of these things have been tried over the years. The best kind of approximation of this is what we call the Resilia valve, which is currently kind of being investigated as well as used in some patients. And what it is it's not the patient's own tissues, but they completely decellularize and take out the extracellular matrix. And the only thing that's left is really just kind of just a microarchitecture that is seeded, with basically still fibrotic tissue. So kind of, but I think it's going to be tough because it's, to grow a valve, where will you take it from? Is it going to be from the pericardium? Most of these patients are not actually aortic pig valves or cow valves. They're cow pericardium that's sutured onto the valve. So I think you need something that's thin enough. But the Resilia is the closest approximation. When the BioStar was, Jim Locke's baby way back, and he wanted to do this in terms of completely bioabsorbable, I think the amount of inflammation still was significant, although a lot of it was the patient's own cells invading and trying to create a lot of fibrosis and endothelialization. So I think it will happen someday, kind of, but maybe transgenic, rapidly growing science fiction animals, but that's far from today.
Roger, that was a real tour de force. I remember in the early 2010s, I asked our mutual friend, Bill Colossus, how much do these things cost? He said, $30-some thousand. Every 2 years, I've been asking the same question. I get the same answer, $30-some thousand versus $3,000. What are the prospects for the prices coming down? Are there enough new valves coming out? Will that ever change?
So I think that's a great question. And, kind of part of the issue, there has not been a driving force to lower the cost. In Europe, the Sapien valve and the Medtronic valve is $10,000 less. So I think, yes. And part of it is they have more valves. And then hopefully with the Abbott valve that's coming out, the Portico, the thought is that they might sell it a bit cheaper to kind of get some market share, and that might drive the prices down. However, even with that high price and, with rebates and all of these, we pay much less, particularly between BI Lahey system. But even with that high price tag, the contribution margin is kind of starting to exceed the surgical contribution margin. And part of it is with the nurse-led sedation, with use of cath labs instead of ORs, with the streamlined next day discharge. All of these things have reduced the cost. One day ICU stay is, kind of quite expensive. And if we can avoid the ICU stay in many of these patients, send them home the next morning.
I agree 100%, but that doesn't mean that Medtronic deserves an extra.
You should be the negotiator of the government, kind of with Medtronic. But I think it will come down, kind of as more valves. Boston Scientific has a valve, Accurate Neo, as well as Abbott has a valve, called Portico. And hopefully both, if they come at the same time, it will cause a $5,000-6,000 drop in the price of valves.
I know you mentioned this a little bit with the tricuspid valve, oral now, and you mentioned the liver congestion. Is there going to be any of the studies, are they going to actually look at cirrhosis as an outcome? I know that there was a question about survival, but function capacity improving and quality of life, but what about
No, of course. I'm sorry. Of course, Marwa's question is, with the tricuspid, I think it's all in novel space. We really kind of didn't know that anything would work. And this was the first improvement in quality of life. Unfortunately, a lot of the cirrhotic patients were completely excluded from a lot of the randomized trials, for obvious reasons. But again, I think as the approval of the TriClip nears, I think it's going to be a lot of investigator-sponsored studies that would look specifically at cirrhotic patients and liver congestions.
Sorry, I meant it as an outcome, like time to, will a patient develop cirrhosis as an outcome?
So a lot of it hasn't been, it's not part of the studies, but I think that's a great thing that we can bring up to the steering committee, that, it's easy to look at. It's not a lot of patients, but I think it is important to look at, as well as the lead related TRs and all of these issues. Thank you so much.